So the first question is what is the clinical role of iodic acid in type 2 diabetes? This is asked by Dr. Shruti Setu. See, the clinical role is that's what we all the time we discussed about this the clinical role of the insulin degludec aspart, a co-formulation which is unique in the world, first of its kind in the world, that has got a wonderful role in type 2 diabetes, that is with the dosage flexibility and the convenience to the patient and the low incidence of hypoglycemia and a better fasting plasma glucose control and a better postprandial plasma glucose control and a better reductions in the A1C. These are all the greatest advantages of the co-formulations, and you can start it OD, and if it is not sufficient, if it is not able to control the fasting, the postprandial in a very effective way, or the dose exceeds more than 40 units a day, then it is high time you have to switch over to the BID usage of this particular insulin degludec and aspart co-formulation. And does co-formulation is first injectable in type 2 diabetes by Dr. Muni Kumar? Does co-formulation is first? See, all the time I never endorse everybody to use co-formulation as first drug of choice. All the time type 2 diabetes, we start with the diet and exercise and metformin inevitably. And of late, the 2019, the Barcelona EASD, the European Association for the Study of the Diabetes, where the results of the verified trial were rolled out in 2019, where I was one of the principal investigators of that verified trial. What it says is the longevity and the efficacy and the duration of the metformin is increased when metformin is added to vildagliptin in the beginning of the course, like diet, exercise, and metformin. And now it is high time, as per the results of the verified trial, you have to add a vildagliptin or choice. It is verified trial is done with this vildagliptin actually. So if you are fond of the sitagliptin, which is off patented, you can also use this sitagliptin. So when you try with this the insulin sensitizer first, and all the time the take home message is that the treatment of type 2 diabetes starts with the diet, exercise, reduction of weight, cessation of smoking, and cessation of alcohol. And the first drug of choice is all the time metformin, unless otherwise it is contraindicated or it is not tolerated by the patient because of its gastrointestinal side effects like abdominal discomfort or the nausea or the vomiting or the diarrhea or the constipation. Unless otherwise the patient has this, the dictum is that you should start with the metformin with low dose, slowly increment it so fast. And now that this after the 2019, the verified results have rolled out, saying that the metformin works only for a period of 3 years, and addition of vildagliptin, according to the verified trial, the longevity, that is the duration and the efficacy of metformin from 3 years is doubled. That is very very efficacious until the 6th year actually, at the time of diagnosis to first 6 years. So that is, it is almost doubled with addition of one DPP4 inhibitor. And the best combination I would suggest is now the combination of metformin and the DPP4 inhibitor and the SGLT2 inhibitor, the off-patented, the generic forms of dapagliflozin, the three drug combination, the triple drug combinations have come into our Indian market, which are very very affordable to the patient, around the 1000 milligram of metformin and either the 100 milligram of vildagliptin or the 100 milligram of sitagliptin, the 10 milligram of dapagliflozin is available below 20 rupees. So you can start this particular combination, and when you feel that the patient is not able to maintain the fasting plasma glucose or the postprandial plasma glucose or the reasonable A1C, the target recommended by the American Diabetes, it is around or less than 7, or the American College of Endocrinology and the American Association for the Clinical Endocrinology, that is ACE bar AAS, which says the A1C should be less than 6.5 for a better the compliance and for the better results in the reductions of the complications. So if you cannot meet these with the triple drug combination, it is high time you have to start insulin, either in the form of, like, initially you can try with a basal insulin, and if it is not successful, if the basal insulin dose is more than 40 units and it is not able to control this, because basal insulin always can control only fasting, not the postprandial. So the A1C reductions are also very minimal when compared to the co-formulation or the biphasic premixed insulins, whether it is the human insulins or the biphasic premixed analog insulins, or the basal plus or the basal bolus. So then you have to change this basal insulin to the other forms of insulin. See, when the patient can afford to go for this particular co-formulation, because this is the best insulin, this is only for the affordable segment who don't have any sort of money problems. They can just as well go for the best insulin. See, I don't suggest that all patients must be put on this particular the co-formulation. It has got its own advantages, but at the same time, all patients cannot afford to go for this particular combination. So I don't recommend it, as I don't endorse this molecule, because if I want to go for the best, I would prefer certainly this co-formulation in my practice. So as and today, there is no insulin that can beat this particular combination, the co-formulation of insulin degludec, and this is 70%, the ultra long acting basal insulin degludec is 70%, and the prandial insulin aspart is 30%. I think it's very clear. And the next question, Dr. Durga Prasad, hi, hello, and Garima, nice presentation, sir. Thank you so much, ma Garima. Thank you. And Dr. G. Sainath Reddy, can we initiate Rhizodec in GDM? Absolutely not. Absolutely not. It is not a drug of choice in GDM at all. See, GDM, you always can, the first drug of choice in GDM, I would like to highlight, Mr. Sainath Reddy. So, the NPH is the drug of choice in GDM, followed by the rapid acting, that is the Actrapid and the NPH. These are the drugs, and off late you can go for this particular, when you require this both the components, you can go for the biphasic premixed human insulins, and you want to go for a basal insulin. See, this particular the Detimar, the Livamir from Novo Nordisk is absolutely indicated in the treatment of this GDM. GDM also requires diet and the exercise, absolutely. Along with this particular insulins, if it is required, only 50% of the GDM patients they require insulin, and there is no role of any oral anti-diabetic medications like metformin. Otherwise, it is a case of PCOS. From the beginning, we had put the patient on PCO, this metformin for PCOS, and the patient eventually goes on for this pregnancy, conceives, and we can continue insulin, this particular metformin, and along with insulin only it can be controlled. Even in that case, the PCOS also, alone metformin cannot control very effectively. You need some units of this particular insulin, and there is no role of glyburate, that is the glibenclamide. We call it glibenclamide. And the Western scenario, the US, Canada, and the UK and the Europe, they call it glyburate. There is no international organization which has advised the usage of orals in GDM. So far it is not endorsed by the international the organizations. We cannot go for this particular the usage of the OADs, and rhizodic is absolutely contraindicated. And Garima, sir, can we divide the insulin into two times? Yes, absolutely, Garima. That's what I said. Insulin, to start with, like basal insulin, we start with this 10 units of basal insulin at usually during the night post lunch, that is 10 o'clock. If it exceeds, if it fails to maintain along with the existing OADs, and if it exceeds the dose of 40 units a day, you can as well go for the BID preparations, that is the biphasic premixed human insulins or the biphasic premixed the analogs, or the patient can afford to go for this particular coformulation. Coformulation is the best, that is the. And yeah, Humayun Hussain, my friend from Gulf, I think, yes. Yeah, can it be used in type 1 diabetes in place of basal bolus insulin? Now that the recommendations have rolled out very recently, that degludec can be given to the type 1 patients above the age of 1 year. Above the age of 1 year, the patients suffering from type 1 diabetes can be put on this particular the combination of coformulation, Humayun. And Haresh Jumani, can we add GLP-1 receptor injection with rhizodic injection? Yes, Haresh Jumani. Absolutely, I said you can always use this the insulin degludec and aspart, the brand name being the rhizodic, can be combined with the GLP-1 receptor agonist, whether it is the liraglutide or the semaglutide once a week. But only thing is, you have to reduce the dose of this particular the rhizodic, that is the insulin degludec and aspart, to prevent hypoglycemia, because GLP-1 receptor agonists, they are potent anti-hyperglycemic injectable agents other than the insulins. So there is no contraindication. Absolutely, it can be combined with all the, like you can combine with metformin, you can combine with barring sulfonylurea and the pioglitazone, the alpha glucosidase inhibitors and the DPP4 inhibitors and the SGLT2 inhibitors, and in association with the GLP-1 receptor agonists also, this coformulation can be used without any hesitation. And only thing is, you have to take off sulfonylurea because of the fear of the level 3 hypoglycemia, which can be sometimes very lethal. That is, even the patient loses the life. And the second thing is, the pioglitazone is addition of pioglitazone is a contraindication for initiation of insulin, because that includes the body fluids and the volume overloaded state. Added to that, insulin also, it increases the fluid level. So when two agents are combined, so there may be like a state called volume overloaded state, where this can lead to sudden like heart failure, whatever it may be. So say volume overloaded state is not advised. So never combine the sulfonylureas for the fear of this particular hypoglycemia with this insulin degludec or with any insulin, and never combine pioglitazone for the fear of sudden heart failure, acute heart failures. And Humayun Hussain, excellent webinar as usual. Thank you so much, Dr. Humayun Hussain. And Humayun, thank you, sir, for the reply. Thank you so much, my dear friend Humayun, Thank you so much for joining. In spite of the odd hours, you have joined the session. Thank you so much. Are there any questions? Is there any facility to unmute and ask? No facility. Acha. So far I find only these questions. So if there are any questions, please, okay, I'll wait for another couple of minutes so that you can type the questions and put it in the chat box, please. And it's a wonder that I missed my good friend S.R. Aravindan from Coimbatore. All the time he makes the sessions very lively with his wonderful questions.
Gariman, Guruswami,
Yeah,
Humayun, Jayasri,
Humayun is my good friend from Gulf.
yes, sir. Praveen Lancer, Rahul Malhotra, Ghosh, Atanu Ghosh, Dr. Atanu Ghosh,
These are all.
Dr. K.L. Narasimha.
Yeah. If there are no questions, may I request the non-artist people to wind up this session?
Yes, sir. Thank you, sir. Thank you very much for your nice presentation on given topic.
And
I'm no thanks to no special thanks to Dr. Sepuri Krishna Mohan sir for your valuable time here, and I thanks to all the audience, those who are joined no from
Yeah.
Gulf and from no other parts of the country.
all
thank
parts
you-
of the country.
All part of the country.
And I express my sincere thanks and gratitude to the my professional colleagues who have joined all the way from abroad and from different parts of the country. Like Garima, she hails from Indore, Madhya Pradesh. So many people from Tamil Nadu, Karnataka, and so many people from Kerala. Thank you so much once again for your patient listening. Thank you so much.
Thank you, Ananda.